Thank you all for coming out on a rather interesting evening weather-wise. But we have something that's going to warm you up tonight. A great lecture by Nancy Fitch. I want to tell you a little bit about Nancy's background. Nancy is an independent consultant in international health. She works for a newly established firm, the Institute for Collaborative Development. And she specializes in health financing and health systems strengthening. She previously worked for 7 years at the Elizabeth Glaser Pediatric AIDS Foundation. She was the foundation's Director of Sustainability and Health Systems, and she served in 3 different positions, most recently overseeing efforts to strengthen national and locally led HIV and primary health services systems in 12 African countries. Prior to September 2011, Dr. Fitch served as the country director for the Foundation's program in Mozambique, where she oversaw programmatic research and advocacy initiatives. Her areas of technical expertise include HIV/AIDS prevention, which is the topic of her talk tonight, care and treatment, family medicine and primary health care, reproductive health, health service delivery, performance-based financing, a very important part of this whole picture, health system strengthening, and quality improvement. Dr. Fitch served first as the country director for the Foundation's Rwanda program before she joined the Mozambique office in 2008. Previous to her work with the Foundation, Dr. Fitch served in various roles at the U.S. Agency for International Development in Rwanda, including HIV/AIDS technical advisor, and she oversaw the first 2 years of USAID's HIV Rwanda program. She also served as a primary care advisor to the Ministry of Health in Armenia, and for 11 years, and this is particularly important, I think, to me because this is where I first knew her. For 11 years, she was director of the University of Montana's Student Health Service. Dr. Fitch has a bachelor's degree in fine art from Brown University, a degree in medicine from Duke University School of Medicine, and she completed her residency in family medicine at the University of Minnesota Hospitals. So certainly a really global health practitioner. Please join me in welcoming Nancy.
Can you hear me? The biggest risk tonight is that I will talk too much. I'm trying to tell a 30-year story in 40 minutes, so I'll do my best to go through the slides. The pictures may have nothing to do with the content on the slides. They're just pictures that I brought from my work in Africa because I wanted to humanize a lot of statistics and numbers. But if you want to ask me about any of the pictures, we can go back there. So I had the real honor and privilege of living and working with my husband, Regan Whitworth, in Rwanda for 4 years and then Mozambique for 3 years, working on the U.S. government's plan to scale up HIV care and treatment services. So I'm briefly going to talk about the history of HIV/AIDS, because it's a history that also took place during my life the last 30 years, and I think other people my age also can identify with some of the history. And then the global response to the HIV epidemic, because that's had a big impact, where we are right now with the current epidemic and what are the issues for the future. So just the history of HIV. We probably remember the top part in the US and in developed countries that HIV hit this country. Actually, some of you may not remember this. You were born after HIV was well established. But for those old farts in here, we remember when in the early 80s that there were homosexuals, hemophiliacs, and Haitians who suddenly started dying of fevers and common infections that seemed to run out of control. And that infection sort of spread rapidly in particular groups of people where it was rapidly spread. In 1985, I think we developed an HIV test, so we were able to isolate the virus and study it. And in the early 90s, the first anti-retroviral medication, AZT, I think, was introduced. And by the late 90s, there was a development of called highly active anti-retroviral treatment that I'm going to call ART. And it's a combination of drugs that actually was very effective in suppressing the virus and made a huge difference in the course of the epidemic. So still, there is plenty of HIV in this country. There's about 50,000 infections a year. By and large, it's concentrated in certain high-risk groups. And we'll talk a bit more about that. Now, in Africa, it's a whole different, it's another world. It's a different disease. It's not a different disease. It's the same disease, but it's had a whole different way of impacting life in Africa. It originally, probably mutated from a chimpanzee virus in Cameroon in the 1930s. It spread very slowly among certain risk groups and along certain migration paths. It really wasn't recognized in Africa, or it wasn't understood other than as a disease where people were suddenly dying. They lost a lot of weight, they got very sick, it went on for a while, and people died. So there was no research being done. They didn't know what was causing this disease. And it spread slowly towards southern Africa for decades, transmitted by certain groups of people. It was certainly transmitted more rapidly in groups, men who have sex with men, female sex workers, uncircumcised men, and it also followed the large migration patterns that took place in Africa, where people migrated from various places to southern Africa where they could earn more money. So if you look here, this is 5 different time periods in Africa, starting in 1982 to 2005. And initially, when the virus started, I think that is Cameroon. No, that's, anyway, the colored places are where the virus was first reported. You'll see Tanzania here, Uganda, and Rwanda. In 1987, it started spreading. 1992, it gradually started moving towards the southern part. In 1997, what I see is an inexorable progression of a major disease where it's just taking over a continent. Starting in 2005, you can see some countries that were dark red actually were getting better, particularly Kenya and Tanzania. But you'll see that it's a rampant disease that's just taking over a continent, having a huge impact. So what was the impact of HIV in Africa? It was terrible. It was way beyond what we saw in this country. Hospitals were overflowing and overwhelmed. The beds had multiple patients to a bed. Over half of them had HIV. The number of orphans was just huge. It truly impacted everybody in Africa, certainly in those countries that I pointed out. There were declining school enrollments. Oopsie, sorry. Families, every family I met in Africa had adopted children and orphans and took them in because all these orphans had their parents dying. The number of children living on the streets increased. The number of households headed by children was greatly increased because their parents had died. Women who were HIV positive were thrown out of households and took up prostitution, which was the last thing they needed to do. The workforce actually decreased. Life expectancy went down by almost 20 years. That's huge. While the rest of the world, our life expectancy is continually going up, you saw a huge impact. And their economy suffered dramatically. Workforces decreased by 15 to 20%, certainly more in the countries that were more highly impacted. A big sign of economic progress was the development of coffin makers because so many people were dying. But now they're going out of business. I guess that's good news. This is in Lesotho. So where are we now a bit? This is from 2012. And Africa, you see, is the continent with all the dark blue and black colored ones that show that there's over 5, 10, or over 10% prevalence rate. Certainly the epicenter of the epidemic right now is in southern Africa. And that's really, again, because there's a brain drain of people looking for work, certainly single men, moving towards Africa, and particularly the mines in southern Africa. So that reflects both lack of net migration as well as lack of circumcision in southern Africa. So that's where the epidemic has moved. And of 35 million people infected in the world, 25 million of them live in sub-Saharan Africa. So I'm going to talk about Africa. Africa has historically many burdens. It certainly is the poorest continent in the world. This is life expectancy, but I had a whole host of maps, whether it was, global health burden or GDP. Africa stands out as the continent with the worst statistics. And this was true prior to AIDS, and it got much worse after AIDS. So it has, by the least developed continent, or the poorest continent, that has many meanings, but one of the things it also means it has the fewest health workers per capita. And if you look at the countries with critical shortages of health workers, you'll see that Africa stands out. You might note that the southern Africa with the worst AIDS infection, these are actually middle income or high income countries. South Africa is technically a high income country, and that has a lot to do with the history of apartheid and the fact that the whites who lived in Africa actually were responsible for the economic development there. They've continued to be higher income, but it's also true that there's really two different countries occupying the same space. There's a white part of the country that has a much higher income than a black part of the country. And apartheid still is playing out there. So if you actually, the point of this slide is to divide the number of health workers by the burden of disease. So how much work do the limited number of health workers have to do in the country? And you'll see that the countries that have the most health workers and the least disease are the developed countries, and where we live here, and the continent with the greatest health burden and the least and the most where health workers are needed the greatest are in Africa. And there actually is a linear correlation between survival rate and number of health workers. So this is one of the explanations why Africa has such poor statistics. What is the epidemic? In Africa, the epidemic is a lot about women and orphans. This is a woman in Lesotho who has taken in all these children. But like anywhere in the world, HIV is spread by blood, placental fluids, breast milk, penile, and vaginal secretions. And these are really important things to understand, even though the epidemics in Africa are what we call generalized epidemics that have spread to involve women and children. They're not just restricted to high-risk groups. In fact, the largest group of people infected in Africa are women of young adult age from 20 to 49. So something like nearly 60% of people with HIV in Africa are women. But these core groups here are still what's leading the infection. They are what we call the core transmitters. Women are hit by many things in Africa. Women are economically vulnerable. They're certainly less educated. They have less economic power. They experience sexual violence more. But there's a lot of reasons why women are the largest population group with HIV in Africa, unlike the epidemic here in the US or in developed countries. And if you look at this slide here, it's not really related to this, but are these high-risk groups? Well, how can you tell by looking? This man, this is in Lesotho, he could well work in the mines in South Africa. What that means is they leave their home and they live somewhere else for 11 months of the year. So it's not surprising that they often have two families, one near the mines and one at home. And this woman is a sexual contact of what is possibly a transmitter here, and she can transmit to her child. That's very common in Africa. So what has the global response been? It's been very interesting. After a decade of watching the developed world get in charge of their HIV epidemic with ART, there was a slow and reluctant, or slow movement to address HIV in Africa. In 2001, the United Nations recommended a commitment to scaling up ART, but nothing really happened until 2003, when the US government, when George Bush, of all people, made a commitment to fund the biggest health program in history. So there's never been a health effort as large as this commitment to HIV. That's in terms of money, people, time. So it is the largest sustained health program ever in the world to date. And in that, I'm also talking about the Global Fund Against AIDS, Tuberculosis, and Malaria, of which the U.S. is the biggest donor as well. It's called the President's Emergency Plan for AIDS Relief. They were my employer that's where the money to employ me for about 12 years came from. It had, initially in the early years, it had an emphasis on abstinence, which gave it a lot of bad press. It also had an anti-prostitution focus. Basically, any recipient of funds had to say they weren't pro-prostitution, which made it tricky if you actually wanted to work with prostitutes and provide them medical care. Now the emphasis is more on know your epidemiology, know your risk group. There were 15 countries. I'll show you the map shortly. It was a multi-agency effort, which means that many branches of the US government, none of which were identified to be in charge and caused numerous headaches in dealing with them, all were active in implementing this. They worked through international NGOs, and that's how I got funded, but that certainly was very good at an emergency response of urgently jumping in and trying to save lives. It's not the way it should be structured for a long-term response, and so part of the effort is helping to build national health systems so that they can receive funding direct from the US government and take over the work. So it's not always dependent upon NGOs. The way it was structured in the beginning, it made my life miserable in that we were always reporting on how many cases were prevented, how many people were cared for, how many people were started on ART, but there were some 20 indicators that were tremendously important to always present this data back to Congress, back to the USAID, who then in turn presented it to Congress to justify ongoing funding. It's just an interesting way to structure a program. We formed partnerships with ministries of health. All these countries have national health systems, and it was the national health systems that are responsible for providing care and treatment to poor people, which by and large HIV people often are. And I think it was a learning effort, although it was a political effort as well. Anyway. The red countries were the 15 focus countries, but really the program covered every country that is colored blue or red. So it was a really huge global effort. I'm going to talk just a little bit about anti-retroviral therapy because really the program was about scaling up this. So, and many things about anti-retroviral therapy are important because it influenced the way we worked. It is a combination of 3 different classes of drug which suppress, but they don't eradicate HIV, meaning they control it, but they don't cure the infection. Therefore, it requires very regular, lifelong medication and monitoring. By regular, in the early days, that often meant 4 times a day, and the doses had to be taken. You had to set your clock and wake up in the middle of the night to take your drugs. Fortunately, by now, there's long-acting preparations, and it's down, instead of some 30 pills a day, it's down to 1 pill a day. So that has helped a lot. It's very important that you take it properly, because if you don't, the virus becomes resistant to the medication. And one of the problems that HIV treatment has had in developed countries is that we've used a whole cocktail of different drugs, and there's a lot of resistance around. In Africa, because this was a very somewhat planned effort, we have avoided that to some extent. Also, managing side effects is an important part of the management of the disease. That these are not benign drugs without side effects, so it does require ongoing chronic therapy. As I said, the dosing has improved dramatically. There's no cure. And ART prevents also prevents the infection. This is terribly important because we want to stop the infection from spreading. One of the largest groups, probably the single largest group, are what we call discordant couples, where the people are in a coupled relationship and one half of the partnership is infected, and we want to stop the other half from getting it. So you use ART as a way of preventing infection as well as treating the disease. And this is because Africans are great dancers and love to dance. So part of this whole program was about scaling up the treatment. And it started slowly, but you can see that it went from 50,000 people. Now it's projected to reach 15 million people, which is approximately half of the people with HIV infection in Africa. So it was, you can see that the curve rate has increased exponentially. But it took several adaptations in order to put it into place into low-income countries. Initially, we said the sickest patients had the highest priority. So we started, the initial activity started at the big hospitals in Africa. So we went to the biggest facilities in the largest cities and set up ART clinics, and that was usually within an HIV clinic. And as we've decentralized, we've had to go from the specialized hospitals to the rural health centers in small little places that might have only one nurse. They may not have a doctor. And how do you decentralize ART to a facility like that, which may not have running water or electricity? And as we also went from the sickest patients to a lot more patients. The standard of care in developed countries is really to put people on ART fairly early in their infection. So we went from treating people on death's doorstep to now treating people who may not have any symptoms at all. In general, in all the countries that have implemented this, we use a single line therapy, which means it's a combination treatment, and some 95% of people take the first line treatment. Second line treatment is for more complicated cases or drug treatment failures, but in general, it's emphasized one treatment. Very simplified protocols. CD4 testing, CD4 is a test that tells you how advanced the disease it is, so when we prioritize people, we do this test, but it's a machine that is only usually in reference facilities, so you have to organize blood to be drawn in peripheral settings, the blood shipped to where the machine is, the results taken, the results sent back. That all is complicated to do. So in places where we want to prioritize people, such as pregnant women, we don't require that test. We just go ahead and treat any HIV-positive pregnant woman who walks in the door, and we treat them that day. It involves task shifting to less skilled workers, so we have a whole lot of the care and treatment, such as counseling and making sure people get to their visits, done by unskilled workers, or not professionally trained or certified. These could be community members who are given a couple days worth of training. And we also then integrate the HIV testing. We have to do that integrated into normal medical care, whether women are coming in for family planning or antenatal care or immunizations. Any of those facilities now have to be prepared to offer ART. So to get all this done, there's a whole host of other things we did, from construction, electricity, internet, phones, computers, buying equipment, community education, women's empowerment, setting up national health policy, setting up local insurance programs. How do you pay for services? How do you train health workers? This is actually the category that was probably the largest category of expenditures, was paying people to just do the work. And that was also one of the most complicated things. Was often we recruited trained nurses away from the national health system to work in HIV programs, which ultimately was not very good for the system we're trying to help. So research, support to orphans, capacity building. In fact, this is a group of HIV-positive kids who are doing great. This is one of the clinics we started work in. This was the sterilization department, which consisted of a big pot and a stove and a fire underneath the stove. So these were some of the conditions we worked in. This is actually a renovated clinic, but it's a fairly chaotic scene with lots of things going on. One of the ways you prevent HIV infection that we learned not until 2009 was that circumcision dramatically decreases the risk of HIV infection. So once this was truly appreciated, setting up voluntary male circumcision programs became a large activity. This is sort of a reality slide. It sounds like a great success, but this is where we are right now. Of 100% of people who are HIV positive right now or in 2012, only about half of them actually have been tested and know that they're HIV positive. So the other half have yet to be tested and don't know they're positive. Of the people who know they're positive, only half of them, or 32%, actually are receiving medication. And of those who are receiving medication, only about 24% actually have a high enough dose to suppress their virus. So even though I show you these slides of great successes in scaling up, the reality is all these gray things are people who are potentially infectious. So there still is a long way to go. One of the interesting reasons for not doing this in the early days was how expensive ART was. And in the early days, I think just the cost of the drug alone cost $10,000 to $20,000 in the US. But as the volume of patients went up and as efforts went up to help build factories that produce drugs or help the private sector develop drugs and develop quality drugs. And so this had to do with a lot of complicated issues, from drug copyright laws to setting up pre-qualification systems that the FDA would recognize, because the original legislation for PEPFAR required that all the drugs be FDA approved. And of course, the FDA, to be licensed in the US, usually requires that the drugs cost a whole lot more, because people in the US will pay a lot more for drugs. So it was very complicated figuring out a rapid FDA certification system where they would approve drugs that had been pre-qualified by the World Health Organization. But nonetheless, you can see that at this point, you can buy a year's worth of medication for under $100 per person in Africa, a huge drop. One of my friends told me drugs in the US still probably cost $13,000 or $14,000 per person per year. So good reason for health reform. But you'll see also the number of patients went up and the cost of drugs went way down. This is just the impact on the average life expectancy in rural South Africa, where the prevalence of HIV is some 25%. But you can see that life expectancy dropped until 2004, went from 60 years of age down to about 48, and now back up is 60. So that's huge. I mean, if you want to feel like you're having an impact, this is something that works. This is the number of people who were tested, sex workers who were tested. And each of these lines is a different country. And I guess the point I wanted to make is you can see impact. You don't see the great performance you'd like. You know, some of the countries are stars. Some of the countries, Eritrea, for example, is doing terribly. The Democratic Republic of Congo, you know, less than 10% of sex workers have been HIV tested, so we've got a long ways to go. But the point is that Africa is made up of some 54 countries. They're all very different places, and we've had great successes in some countries, and we've got a long ways to go in others. This is just a message of the scale of what happened in South Africa. South Africa, I think, has a population of 50 million or so. I'm somewhere in there. In 1 year, they tested 13 million people, 2.2 million tested positive, and 400,000 people in 1 year were started ART, including 57,000 pregnant women. 8 million people screened for TB, 185 million condoms were distributed. That just makes me think of the plumbing headaches there. Anyway, you can think of the scale that went on here. How did we pay for all this? How much did it cost? As I said, this is the largest program in history. These are in thousands of dollars, so this is $2 billion. This is $6 billion a year. So you can see the funding went up dramatically until 2008, the year of the big finance problem here in the US, and it has flatlined since then. Of note is, even though it's flatlined, those enrollment numbers go up year after year. The light blue is the amount of money going to the Global Fund, and the dark blue is the amount of money that's gone to PEPFAR. These are US dollars. Now, we estimate that right now, currently, the amount of money going to HIV is $19 billion a year, so the US is paying for about a third of that, and other countries are paying for the rest. The US has put the bulk of its money into HIV, so a lot of money that used to go into family planning or other international health programs now goes into HIV, so it's not been all new money. A lot of it is new money. Most of it is new money, but not all of it. And if you want to calculate, which we will shortly, the amount of money needed to actually provide everybody with HIV ART, which is needed because otherwise they'll infect a lot more people, it would probably cost $22 to $24 billion a year. So this is a lot of money. But this very complicated slide is what it would, can African countries, are they ready to fund their own services yet? Because we hope someday they will. And over here, what we have ordered here on this is countries by HIV prevalence. So Swaziland has the highest prevalence in the world. So these 5 countries are the really high prevalence countries in South Africa, going down to less prevalent countries. The blue line is their overall health domestic expenditures, non-HIV, and the red is HIV. And looking at these countries down here, these are higher income countries, and some of them are doing really well. Namibia and Botswana. Botswana already is funding their own HIV program. The other ones are not doing so well, but South Africa is putting a lot of domestic funding into there. So I think there's been a big increase in their taking over these expenditures. But then we come to the problem countries like Mozambique and Malawi, where they're funding hardly any, less than 10% of their own HIV program, and international funds are paying the rest. These are pretty poor countries. Mozambique, Malawi, they're not going to be able to pay for it in a long time. So the international community, if we recognize that it's in our self-interest to fund this thing, and I will argue that it is, we need to just, let's be realistic, we're going to keep funding this for a while. And then, so those are the 2 points I wanted to make from this slide here. And again, sort of looking at how much funding are they getting and how many HIV positive people do they have. So this is the HIV prevalence versus what their own economic finance is. You will see Botswana is in good shape. They're spending of their own money an average of $200 per HIV positive person per year. They're doing pretty well. Namibia is also doing pretty well. And you have the low performers down here. Mozambique, I can talk about since I live there. They're spending an average of $7 per HIV positive person per year. So that isn't near enough to fund what they need to fund. But this is on of 180 some countries in the world, they're in the bottom 10 in terms of GDP per capita. They're really, really poor country. They're not going to fund it for a while. But is ART worth it? Okay, so these are 2 curves. This is what would happen to the number of HIV deaths that would occur in a country without ART. It would keep going up like those inexorably advancing countries on those maps I showed earlier. That's what would happen without treatment, and this is what is happening with treatment. So in terms of helping these countries get on their feet and become economically solvent, they need to take care of their HIV epidemic. I guess I'd also say that even Mozambique has averaged more than a 5% increase in their GDP per year in the last 10 years. So Africa is actually coming along in terms of economic development. But they clearly need to manage this HIV epidemic. And the point of this complicated slide is to show that while there is greater investment needed early, the faster you get everybody on ART, the sooner you will have control of your epidemic. So the fact that we waited a long time to support this basically meant that we have a much bigger mortgage to pay off. So you can save yourself long-term costs by jumping in early. And just again, some hope. This is the impact on infections of children. I worked for the Pediatric AIDS organization. They care a whole lot about 0 infants being infected. And this is the point that they're saying is statistically 0 if you get below 50,000 infections a year. And we're pretty on track to reach that by 2015. So there has been some huge landmarks that we have achieved from this program. It's had amazing results. Lastly, this is sort of the same slide, that it pays to be active early. These are the countries that have had impact on their epidemic. These are countries that now have more than 60% coverage of ART. Malawi, Namibia, Botswana, Zambia. And they're the countries that have had the greatest fall off in new infections. And these are the poor performers, Nigeria and Angola. They're doing terribly, and they have had basically no slowdown in their rate of infections. Now, they're slow and poor performing for a host of political and economic reasons, and it's not just a matter of will helping those countries move along. Lastly, this is the slide I got mixed up earlier. Okay, these are percent of people who've been tested. And again, the point here is that there's good performers. Rwanda is a spectacular performer that has tested over 70% of people in the men who are eligible. And then again, we have countries down here that are not doing so well. They're the ones that are bad for other reasons, whether it's Congo or other countries where there's conflict there. But it's not everybody's doing well. And there, I would say behavior change has been less successful, unfortunately. But the percent of the population, after all these years of this big program going into Africa that have comprehensive knowledge of HIV, hasn't changed a whole lot, nor like the US, I would also say, there hasn't been huge change in behavior in condom use among high-risk sex. So some things have worked better than others. Lastly, the District of Columbia has a prevalence of 3.2%. That's worse than Ethiopia, Rwanda, Congo. So we have some work to do in our own country here as well. Okay. The future. That's what this is about. Can African countries fund and manage their own HIV response? Well, where we are right now is really, it's been over 10 years. We need to move from an emergency response to really figuring out how countries can take over and own their HIV program. Because right now, if the international NGOs pulled out or if the US cut our money, I think we'd be back into where the epidemic was progressing. We have to recognize that it has to be managed by national health systems. It's not a cure. It's not something that we can fix in 5 years. All these people on this medication are going to have to take it for the rest of their lives. So we have to have a system where they can go to their local healthcare facility and get managed there. So we really need to work on strengthening health systems. That's why you noticed I no longer work in HIV and I work in trying to build national health systems. I would say the end of AIDS is not in sight yet, but the path to get there is clear. I mean, we've learned a lot of things in the last year. We do need continued aggressive scale-up of ART that needs a lot more than doctors. It needs all of civil society. It needs strengthened health systems. And it needs universal access, something we in this country don't always know a lot about. But we need to help the people who are poor and infected get access to health care in Africa. I would also say there's a ton of hope for Africa here in the US. I think before I went over there, I thought of Africa as a place where there was a lot of barbaric tribal murder. Africa is happening. Africa is full of incredible, empowered people who can make a difference in the world. Lastly, we still need an AIDS vaccine, and I haven't really talked about the development or the problems with developing an AIDS vaccine. That would make all the difference in the world, but it has been a very challenging vaccine to develop, and to my knowledge, there's nothing in the immediate horizon. So there's no alternative to this. So that's it. I got it done. So I'm happy to answer any questions or refer them to my husband. Shan.
Nancy, what was you had a risk factor with herbs?
Yeah, women, There's a sexual practice in Africa to put herbs in your vagina to make it drier, to cause more friction. And that, of course, functions as an abrasive and might be thought of to be a reason to, that women get infected. Yes?
You said that the long-term solution doesn't lie in the NGOs.
Right.
Had you been in charge of implementing the 10-year plan at the get, what would you have done?
Well, it's really easy to be smart in hindsight. Right. I don't know. I mean, it was a lot of things were justified in the name of this is an emergency and we have to save lives. I think in hindsight, you know, there were a lot of mistakes made where we built up the capacity of NGOs. There are a lot of Americans who had good jobs for 10 years. In hindsight, I would have set up large training programs to train more nurses and to also increase the pay scale of nurses, probably. So there are things I would have done differently, but at the time, it was hard to know. Yes?
I have two quick questions. So if you can clarify, you said in South Africa when they tested, 2.2 million tested positive for HIV.
Yes.
But only 400,000 got ART, is that right?
Yes.
Okay. And then, so when you were saying how...
Can I tell you why only 400,000?
Yeah, I just wanted to clarify.
There were waiting lines at the doors of every clinic. It literally was about a capacity, a service delivery capacity issue.
So to that then, what do you think, as far as hindering, spreading the capacity, certain drug companies who are protective of their patents and trademarks, and then challenging other countries' efforts to produce them cheaper? I mean, I don't know if you have anything to say about that.
That's a really complicated issue. I would say it wasn't, lack of drugs didn't limit the scale up. Lack of health workers limited the scale up. That, however, addressing the drug issue was very complicated, and if it hadn't been probably a George Bush priority, it might not have gotten addressed. But he basically told the FDA to figure out a way to pre-qualify and approve these generic drugs manufactured in India. And they did. It took about a year and a half to get that done. But it is true that there are lots of factories manufacturing ART, and you certainly need quality systems to make sure the drugs are not counterfeit and that they're good. MSF and Paul Farmer actually made a huge difference in getting the whole program funded, because they went to Africa on their own money and set up clinics and showed that it was possible to treat people in Africa with first world treatment, and you'd get the same results.
There was a question that it wouldn't happen?
Yeah, there were. Yeah, I mean, for 10 years, the medication was being offered in the U.S. and there was no funding of it in Africa. It took a long time for governments were reluctant to make a commitment to treat a lifelong disease that had cost over $10,000 per person per year to treat in Africa, and it wasn't a cure. It was a lifelong commitment, because once you start people on this treatment, if you ever stop it, they'll die. So yeah. This is my husband who was there with me.
Yeah, there were people in the United States and elsewhere who opposed any kind of treatment program, saying that these are uneducated people, the treatment is complicated, you can't get them to do things, keep track of time, so that they'll have to take a dozen pills a day at different times, and they don't keep schedules like that. It's just hopeless. There's no way to get them to, if you can get them assessed and you give them the drugs, you still won't be able. They won't be able to maintain a schedule, and it'll do more harm than good. And that's I think it's. I'm suspicious of people who find reasons to not try to do some good. But anyway, it was. They had a very elaborate argument about why it was a bad idea to even try. They were wrong, but that's.
You talked about training. Greg brought up the role of education. What are the problems of linking education to delivering best services?
What do you mean? Do you mean?
I mean, if you're delivering medical services, why can't you in tandem deliver education?
Educate consumers or clients, or educate nurses, or?
Whatever, I mean.
You mean why, at the same time
Why
you're
is there
delivering
X number of
services?
dollars going for medical care, and what is the role of education in that? Is there a linking of that in any way?
Very good question. And it took the program probably 5 years to realize we need to be sinking money into education rather than just service delivery. So even though a lot of money went into this, there was always, not enough money to meet the need. And so were you going to put money to build more nurse training sites or medical schools or whatever? Or are you going to just pay salaries of health workers to go, or what are you going to spend the money on? So I would say it was, do you want to save lives today or lives 5 years from now? Okay, so there was a real commitment to training the workforce and to actually to train more, to graduate more nurses and healthcare workers. That probably started like in 2008, 2009. And so now, I think that now as the U.S. government looks at where their money's actually going, the biggest category of expenditures is salaries of health workers. And it doesn't go there directly, but that's what it's paying for. Yes?
Apparently in the village or people who use ART, I think sometimes it is difficult for local people to accept the new medical method or tool people.
Sure. In Africa, a lot of people use traditional healers or local people, non-professionally trained, non-licensed people to get medical care. So there's a huge, very common use of that anyway. But in reality, when this arrived, people were dying, hospitals were overflowing, and there was no question of a demand for services in the first 5 years. Because the volume, there were so many people dying and sick that there were waiting lines at clinics. Then as we started catching up with demand and trying to find people before they got sick, then you actually had to start educating people and dealing with issues that they didn't think they were sick. Why would they need this? Why do they need to walk 50 kilometers to get their medication? And yes, many of those people still don't want treatment. So, yeah.
I'm interested in the interface of HIV/AIDS and healthcare system. You've worked in both areas. So that one statistic that really stood out to me is that of all the people who are estimated to be infected with HIV in Africa today, only about 21% are getting sufficient medication to be able to treat. Is that because of some kind of a failure in the healthcare system? And if so, based on your experience, what do you recommend that can be done to strengthen healthcare system?
I mean, whatever our vision of a health system is, and probably we all have a vision that's based upon our own experience here in the United States. It's a different planet over there. You saw the difference in the number of health workers per volume of disease in the U.S. is like the circle was like this big, and in Africa it's a pinprick. So in general, people have to walk to a facility. They might have to walk 20 kilometers to it. When they get there, the volume of patients is much greater. You don't get shown into a nice, pretty waiting room and sit in a comfortable chair and have. I mean, it's a totally different experience. It's a waiting line where you might have to wait 3 hours, and then you'll see a provider for 2 minutes, and the bulk of your care might be delivered by a non-trained aide. So yes, the whole health system is weak. But even given the fact that it's terribly underfunded, these are developing countries where economic systems don't work well. So you'll still have very unmotivated health workers who might be sitting around and talking rather than seeing this long line of patients that are out there. So In developing countries, you will find things like supply systems don't work. You know, things that we would just take for granted and fix don't work there, because at the end of the day, there's so many things that don't work, that why fix this one problem when there's just something else that will go wrong. So I think the answer to your question is absolutely, it's the health system. Like, it's the economy, stupid. I would say it's the health system over there. The whole system, many parts of the whole system don't function according to what we would expect to work over here. Did that make sense?
Yes. Where did you start? You were there and you were trying to
Where do you start? Yeah.
help strengthen your health system. What can you share with us? What kind of lessons did you learn about where you want to start, where you want to make the greatest impact?
Well, I've sort of done everything. I've tried a whole host of things. At the moment, I'm thinking that financing systems actually are a framework under which everything else is organized. It influences how health workers are paid and what they're motivated to do. A lot of these countries have very bureaucratic civil service systems where it's impossible to fire somebody, it's impossible to reward anyone. And you have a whole host of people who get paid $30 a month to work their tails off, and they're very unmotivated. So you need to look at the whole civil service structure and try and figure out how you create a system that works better. These are developing countries for a reason. They haven't figured out they haven't created systems where of accountability, where at different levels people are both rewarded and motivated and or sanctioned to work effectively. So there's bigger, larger system reasons as to why these are developing countries. If that makes sense. There's systemic things that are not functional there. Any other questions?
Are there any other questions?
Did you see that you told that by funding African countries, the U.S. government is doing a favor to other countries? And in return, what's your reasoning for that?
Why is it in the U.S.'s interest to help save lives in Africa? Well, we're probably getting pretty philosophical here. Because I think the world would be better off if there wasn't such inequality. There would be less migration of people. There would probably be less wars at the end of the day. There'd be more trade. That's just me. I think it'd be good.
Yeah, I think it's a good thing. I think it's a good thing. It's just kind of hard for me to figure out how this country will spend money for another country, which is pretty great, but hard to figure out.
I think here we were in Africa. Africans really appreciate the United States for what it's done over there. It's a whole different reaction than the criticism and feedback we're getting from the rest of the world from our wars in Iraq and Afghanistan. Africans gave George Bush standing ovations. I'd much rather have us have that impact on the world.
It's not an unusual attitude in the United States. It's pretty consistent for the last 20 years or more. If you ask Americans, do you think that the U.S. government spends too much or too little of its budget on foreign assistance, or is it about right? The majority answer is almost always too much. But if you ask what percentage of the budget do you think should go to foreign assistance, the median answer is between 10 and 20%, which is the actual percentage of the budget going to foreign assistance is less than 1%. So what people would actually like to see is 10 to 20 times what we're doing. Just that foreign assistance gets such bad press, that people think that it's where all the money goes, but that's not where it goes.
Well, and just to add to that, in our recent negotiations between Congress and the President, one of the few areas that was not increased in terms of that agreement was foreign assistance. So we are even cutting our foreign assistance more than we have given in the past. But I would also point out that there are many other countries that do an even better job of this than we do. You know, if you look at Scandinavian countries, you look at Holland, for example, you see much higher percentages of countries' gross domestic product devoted to foreign assistance than we do in the United States. So we're not the only ones that do this. And Japan is a good contributor as well. Okay, well, this has been wonderful. I think Nancy gave us a lot to think about, chew on. I was really impressed with the breadth of her coverage and all of the insights that she has based on her research as well as on her experience. One of the things I forgot to mention when I introduced her is I went up to her just before she started and I said, Nancy, is it true you're just back from Mozambique? And she said, no, I'm just back from Pakistan. So I just wanted to let you know that she's not only exclusively working in Africa, she has other places in the world that she's working in. So please join me in thanking Nancy.